I'm going to talk about the socioeconomic disadvantage and how it's associated with poor gray matter health, but not white matter health. So what is Alzheimer's disease? So she already kind of explained it really good, but we're going to talk about the global challenges of Alzheimer's disease, and the prevalence of it. Sorry, next slide. All right, so the prevalence, over 55 million individuals globally live with cognitive disorders, and the AD is the most prevalent, and this number is projected to double by 2050 due to accelerated population aging. So the impact in the US specifically, 1 in 3 older Americans die from it, and for the economic cost, it's predicted spending is set to exceed $1 trillion in 5 to 6 decades. But this still underestimates the full cost, including caregiving burden and personal losses. In terms of etiology, AD impacts multiple brain systems, including cellular level issues, which eventually lead to sympathetic loss and overall brain atrophy. So these ultimately cause cognitive function loss and death. So for socioeconomic status and cognitive health, so the socioeconomic status is defined by education, income, occupation, and access to resources. So the impact of low SES is associated with higher prevalence of cardiovascular disease, diabetes, increased mortality rates, and limited access to preventive health care. So the cognitive aging, low SES is linked with higher risk of dementia, accelerated brain aging, and increased cognitive decline and shorter disability-free lifespan. The multifactorial effects on brain is chronic stress, limited education, and lack of mentally stimulating environments, slow brain development. So these factors eventually weaken the brain's ability to adapt and reduce its backup capacity, making it more vulnerable to disease and decline. So next we have cognitive reserve and education. And so the cognitive reserve theory is, sorry, next slide. So the cognitive reserve theory is higher education, cognitively demanding occupations, and an active social life build mental flexibility, which protects against dementia symptoms, even when brain damage is still present. So education does play a huge role in it, because studies show that more years of education delay dementia onset and improve daily functioning, and are linked to larger brain volumes and healthier hippocampal functions. So for the next slide, we have the risk of AD and how it varies by race and socioeconomic status. So first, let's talk about data collection techniques and what it is. So the composite score of neighborhood income, education, employment, and housing quality, and it's measured by national percentile. And it compares neighborhoods across the U.S. state decile, and it ranks neighborhoods within a state. But state level does matter more, because when it's national, it's more generalized. But when it's state, it reflects on local policies, healthcare access, and resource allocations better than national comparisons. So the research link is higher ADI equals higher risk of mild cognitive impairment, earlier dementia, faster cognitive decline, and smaller brain volume. So for the next slide, we have racial disparities in dementia risk. So the systematic inequalities, discrimination over time has created gaps in SES, healthcare access, and dementia rates. It affected mostly minority communities, since they have a high risk of dementia, probably due to environmental exposures, but more research is being done on that. And some other confounding factors is obviously education, income, neighborhood quality, that can all affect neuroimaging results. So study cohorts AD and I4, which includes white, African American, Asian, and American Indian participants. So it does allow for a full both social and biological influence. So for the next slide, we have genetic risk and modifiers. So we have APOE, E4 allele, which increases risk for late onset AD, amyloid buildup, hippocampal shrinkage, and white matter changes. But genetics alone do not determine outcome, because social and environmental factors can influence this risk. So if you do have a healthier lifestyle, you're less likely to actually get Alzheimer's, even if you are at risk for it. But the gap in this is a lot of studies examine SES rates and APOE separately. And if you look at gene environmental interactions or diverse populations. So we decided to evaluate existing data by analyzing genetic, social, and environmental factors together. So then we have signs of Alzheimer's in the brain and MRI biomarkers. So an introduction to MRI biomarkers. The purpose of it is it's the study that measures three major MRI biomarkers, providing distinct but complementary information about brain health. So, and it also tracked the progression. So it started from cognitive normal through early and late mild cognitive impairment, MCI. So then we have total brain volume, and it reflects overall brain tissue loss, and its prevalence is it's significant both health and disease. Then we have hippocampal volume, which its role of the hippocampus, it controls knowledge basically, and another one controls awareness. So the AD significance of this is that if the hippocampal increases, you're going to be more likely to not exactly fight off the effects of Alzheimer's disease, and you'll get cognitive decline easily. Then we have white matter lesion volume, and what it is, it's a total measurable volume of white matter lesions in the brain, typically detected using MRI. And the problem is it disrupts brain connectivity and is associated with functional decline, and it may result from hypertension, diabetes, inflammation, and social detriments. So then we have a multifactorial approach for neuro the, I do not know. I keep butchering that word. But anyways, then we have this matters because it strongly affects it's affected by socioeconomic factors, especially in gray matter, meaning where people and how people live really impacts brain health. So this research adds like it shows a clear evidence that social and environmental play a big role in it. So it highlights the importance of looking at multiple factors together to better understand brain aging, dementia risk, and health disparities. So the ADNA, data set, it comes from a public data from the Alzheimer's Disease Neuroimaging Initiative, and it includes 440 adults aged 50 to 94, including people with normal cognition, mild cognitive impairment, and Alzheimer's disease. And it collects brain scans, genetic data, blood tests, cognitive and behavioral assessments, and medical/family history. And it focuses on providing a more socioeconomic viewpoint. So it measured the area deprivation index, which includes nationally and by state years of education, and also self-reported race and cognitive diagnosis to explore different across different groups. So then we have research question and the hypothesis. So how does socioeconomic burden relate to signs of brain degeneration? And our goal was to see if individual and neighborhood socioeconomic status affect brain health measures like BV, HV, and WMLV. So our hypothesis was lower socioeconomic status is linked to poor brain health, smaller brain and hippocampus, and a more white matter lesions. So then we have a statistical method. So as for the data part, it's what they did generally, so we don't really need to know that. But the software that we use to create some figures was Python, and we created charts, and then we also tested for the ANOVA test, which is basically a statistical test that checks whether the means of three or more groups are significantly different from each other, and it just checks their correlation. So if the p-value is more than 5%, then it is not significant. There's not a significant correlation. But if it's less than 5%, there is actually a correlation. And yeah, it just increases the validity of your research. So finally, for the result and conclusions, the study itself, 331 white participants, 74 African Americans, 26 Asians, 6 or more mixed race, and 3 American Indians. This research strategy was to analyze both neighborhood level and individual level socioeconomic disadvantages and their interaction with the genetic risk. So it focused on early Alzheimer's disease indicators and biomarkers, and it tracked it cognitive normal to mild cognitive impairment. So as for results, we found that more years of education are linked to larger brain volume, supporting the idea that educational builds cognitive reserve, and these are all the other significant factors involved. And brain volume naturally declines with age and disease progression, so we kind of already knew that. That's just proven. But for state deprivation, there's high state level socioeconomic deprivation, and it's associated with smaller brain volume, but the national deprivation is insignificant, which is again because there's it's more generalized throughout the whole United States. So for the next slide, this is just the graph, which obviously it shows how the years of education, you're more likely to get cognitively normal than late MCI. And then we have the white matter lesion volume. So it did show that there's no significant link between the volume, suggesting that education alone does not explain white matter lesions differences. And there was nothing really significant about it except the risk. And obviously, older participants had more white matter lesions consistent with normal neurodegeneration. So that adds up already. And then for the next slide, we do have average white matter lesion volume by race, and Native Americans are more at risk. And the reason for that is because there's fewer Native Americans. There was only 3 in the study compared to white, African American, mixed, and Asian. Then we have the hippocampal results. So the state level deprivation decile was 0.003, which is significant. So there is a correlation and it does matter. So there's higher local deprivation and it's linked with smaller hippocampal volume. So it's probably because of different living conditions, healthcare access, chronic stress, nutrition, and medical care. And these are the other non-significant factors that we don't really need to focus too much on. So what this means is localized socioeconomic data captures effects on hippocampal volume better than broader national measures, again, like explained earlier. And then this graph just shows the hippocampal volume across the genetic risk. So the key conclusions that we came to was education does protect the brain. So each additional year of education was linked to higher total brain volume, and that's the p-value supporting the idea of cognitive reserve. And then we have local environment matters because there was higher state level deprivation, which was associated with the smaller total brain volume and smaller hippocampal volume, even though that the national level was not. Again, it's more generalized. And then obviously there was the consistent biological factors like age, sex, and diagnosis, which obviously influenced it. So the takeaway is brain health is shaped by multiple interacting factors: education, local environment, genetics, race, and diagnosis, all across the board. So then we have the public health implications. So interventions targeting education, neighborhood investment, and healthcare access could protect brain structure. And honestly, it would save so much more money than the money that we currently spend on Alzheimer's disease, whether it's research or anything else. So as for our summary and future directions, we do, sorry. So education and state level deprivations are linked to brain measures like total brain volume and hippocampal volume. More years of education equals larger brain volume. Local environment does matter, and white matter lesions was not directly related to educational volume. So we still need to investigate that more. And these are just some possible future things that other researchers can do. So lastly, thank you, Talaria, for giving me this experience. It was wonderful. And I had such an amazing mentor. She helped me throughout this whole process, and she was just always there for me. So, yeah, I really appreciate her.